Good morning, everyone. My name is Maya Luria with TMC for Seniors, and I'm really happy to have Dr. Alexis Chesrow here with me today. She is with Arizona Urology Specialists and is going to be discussing women's bladder issues. Welcome, Dr. Chesrow.
Good morning, everyone. I'm happy to be here. So we have a little bit of a slide presentation for you, but as we go along, feel free to write down your questions. There'll be plenty of time at the end of the presentation to answer individual questions as needed, okay? All right, let's get started. Okay, next slide. All right, a little bit about myself. So I am a board certified urologist, which means we take care of all sorts of urinary issues, the kidneys, the bladder, but I'm also fellowship trained and double boarded in what is called generally urogynecology or female pelvic medicine and reconstructive surgery. So that is women who have prolapse, which is drop bladders, rectoceles, uterine prolapse, and all sorts of complicated incontinence. I also do something called neurourology, which is for patients with complicated neurologic issues, how that can impact the bladder. So I also save a portion of my practice for spinal cord patients, people with Parkinson's, MS, and how that changes how the whole urinary system works. As someone who is fellowship trained in reconstruction, one of my favorite things to do is take women who perhaps have tried other options for their incontinence and haven't been successful, or have had previous prolapse surgeries that have had not the outcomes they wanted, and see what we can do to advance your care as a second opinion. So that's one of the things I enjoy. So today, though, we're going to keep it simple. We're just going to talk about urinary incontinence and go from there. All right, next slide. And next slide. Okay, so urinary incontinence happens to both men and women. We're going to focus on female incontinence today. And what the message we really try and stress is that urinary incontinence is so common. It is actually as common and as expensive to us as a nation as heart disease. But we don't do a good job of putting out the message that, like heart disease, which we know is treatable and things for prevention and intervention, for incontinence, it becomes this quiet issue that many men and women don't know they can really seek treatment for. All right, next slide. And next slide. So this is the part where I just say, this is just plumbing. It's not as complicated as it seems. But what most people have to realize is while you may see leakage on the outside, there's a couple different reasons you can be leaking on the inside, which is why you see someone like me. So I can figure out what type of incontinence you have and then go over it. And often incontinence can be very unique to the person who has it. And there may be more than one issue we need to correct in order to get you better or more dry. So, all right, urge incontinence, that's that sense of overactive bladder. We'll go into this in a little bit more detail. Stress incontinence is leakage with activity, where you feel you can't run, jump, or exercise. And what people have to realize is you can actually have both. And there's different treatments for both. So if you have both, we actually have two issues we need to fix before we get you better. All right, next slide. Okay, so stress incontinence will occur in over 50% of women, okay? Up to 80% of women will have some form of leakage with exercise as they get older. And I can't stress enough that we have so many good treatments for this now. Where back in the day, it was pretty invasive surgeries that may not always have had the best outcomes. We have office-based technology and new research and clinical studies and wonderful things to get women markedly better so they can go back to being active, play golf, exercise, yoga, whatever you want to do. All right. Urge incontinence is surprisingly common. That's overactive bladder. That's when your bladder, starts making you go more often and you feel you have bad bladder control. That is a normal part of aging. And up to a third of women will have both issues. All right, next slide. Okay, urge incontinence. Bear with me. As I said, this is a normal part of aging, and it actually can be really common in patients who have some neurologic issues or have had a head injury, a little bit of dementia, stroke, Alzheimer's, Parkinson's, and some spinal cord issues. And childbirth can be a cause of it, and just normal aging. So urgent incontinence is where this is your bladder gets smaller as you get older and starts holding less. And it also can have spasms. If you've ever had a Charlie horse of your foot where your toes curl, well, if you have a Charlie horse with the bladder, it gets smaller and that urine wants to come out. That's that sense of urgency. And different people can have different presentations of it. Some people don't leak at all, but they go a million times a day. Other people don't go that often, but they get no warning. And all of a sudden, it's urgent and you don't make it to the washroom in time. And it can be very frustrating. Now, I'll touch on people who get up at night too many times. We call that nocturia, and that can be for a variety of medical reasons, not just your bladder getting smaller. So if you get up too much at night, it's definitely worth it to come see us, and we can kind of work through your medical issues and see if this is something we can easily correct, or if it relates to another medical issue. Obstructive sleep apnea is a common cause, heart failure issues. If you get a lot of fluid collecting in your lower legs during the day, guess what? When you go to bed at night, your body processes that fluid and it hits your bladder and you have to get up and go. So it's always worth a good evaluation to see why, unique to you, you're having issues. So we try and make sure that patients understand when you come in for an incontinence evaluation, it's not one size fits all. We take all of your medical issues into consideration. All right, next slide. Okay, stress incontinence. So urgent incontinence was your bladder, the receptacle, gets smaller and more overactive as you get older. Stress incontinence is the valve in the plumbing. So when you cough, jump, that valve should tighten. So when you're doing strenuous activities, you don't leak. Over time, that valve gets weak, and when you put pressure on the valve, it pops open and urine can leak out. So it is just a leaky valve issue. But some women only leak a little bit, and they say, do I really want intervention? Versus other women, it prevents them from doing anything they enjoy because the leakage can be quite profound. So one thing I tell my patients is, how do you decide when, you should get your incontinence fixed? And I say, if it is keeping you from doing things you enjoy, if you are changing how you live and limiting your activities due to any type of incontinence, that's a good time to come in for an evaluation. Okay, next slide. All right, so that leaky valve can actually be for two reasons, and you won't notice a difference. But the reason we bring it up is when we talk about the options for stress incontinence and what I can do as a surgeon or what I can do in the office, there's two types. And depending on your anatomy unique to you and the type of incontinence you have, it helps me choose interventions so you have the best chance of success. So normally, bear with me, bladder, urethra. There's muscles and tendons and ligaments that support your urethra. So when you cough or sneeze, it's very well supported. Hypermobility is when you've lost that support and the urethra flops in the breeze and moves around when you cough, sneeze, or jump, and that can lead to leakage. The second type, intrinsic sphincter deficiency, is that sphincter I was talking to you about that should, when you cough or sneeze, it should tighten. Over time, though, it loses the ability of that valve to close, and the valve stays open and rigid and tight, but not closed. And that leads to a different type of leakage with activity. So we keep those things in mind. And this is why I say incontinence workup, it's unique to the patient, not generalities that work for everybody. Okay, next slide. Okay, so patients ask me often, how did this happen? And, we would love to say there's one thing that can prevent incontinence. So sometimes I use that analogy with heart disease, how common it is. Heart disease, we have wonderful things that are preventative. Unfortunately, for urgent incontinence, which is overactive bladder, or stress incontinence, which is that leaky valve, there's some genetic component and some component that is a normal part of aging. Other things can contribute. Menopause, estrogen changes in the vaginal canal can have a very profound impact on incontinence. Pregnancy, vaginal childbirth, previous surgery, if you've done a lot of heavy lifting and physical activity throughout your life, smoking, and any injury to the pelvic region or the spinal cord. So we take all these things into consideration when we see what we may need to correct in the individual patient. Okay, next slide. Okay, and one thing we like to talk about with mixed incontinence. So we use this term for women who have two reasons they leak, but I stress that it's not actually a real thing. You have urge incontinence and stress incontinence. So there's two issues. It's like saying you need your right and left hip fixed. Okay, you need both things corrected. Otherwise, you're not going to be satisfied with the result. So sometimes we'll use this as an umbrella term for people who have more complicated incontinence, but we always keep in mind mixed incontinence just means you have stress incontinence that has to be corrected with the leaky valve, and urge incontinence, which means we need to address your bladder's ability to hold things appropriately. Okay, next slide. Okay, this is the fun part. This is where we talk about treatments, okay? One thing we do touch on, though, is, incontinence can be very expensive. The cost of pads and laundry and the impact on your social life can be pretty profound. But there's a lot of barriers to treatment where before women and men who had incontinence really thought they just had to live with it. And over the majority of the time, we can have a profound impact on the amount of leakage and get you markedly more dry. I wish we could say we could get everyone 100% dry, but that's not realistic. So when patients come to see me, I have a very clear, realistic discussion with them on, one, their goals. How dry do they want to be for the activities in their life? And two, unique to them, what type of incontinence they have and other factors and health issues that may contribute. And three, then we go through a laundry list of treatment options and choose one that fits that patient uniquely. But back in the day, there was this old adage that women just went from menstrual pads to incontinence pads, and they thought that was a normal process. And we love that there's a new focus on women's health, and that Tucson Medical Center is incredibly supportive of this. And there's so many things we can do. All right, so let's start talking about treatments, and let's go to the next slide. Okay, we're going to start with overactive bladder. So we kind of break things up into mild, moderate, and more invasive options. And for overactive bladder, the best thing to keep in mind is we have lots of options. So first time, we always talk about lifestyle changes first. And when you come to see us, we may have you do actually a fluid diary. We like to know what you're drinking because what goes in must come out. So the main lifestyle changes is if you're drinking just copious amounts of fluid or you have a lot of caffeine in your life, if you put a lot of fluids in, you're going to have to urinate a lot. Now, we do live in a desert, so we all stay hydrated, but within reason. The bladder diary can tell us if you're drinking more than you need for your body size and your activity level, and that's a great lifestyle change. Also, sometimes cutting off fluids about 2 hours before bed definitely helps with the nighttime issues, okay? And this is where you'll hear me talk about this for overactive bladder and for stress incontinence. Pelvic floor physical therapy is a wonderful option for many women, especially our postpartum women right after childbirth. So we have physical therapy for all different parts of our body, sports injuries, spinal injuries. The pelvic floor is actually multiple interlocking muscles, nerves, and ligaments. It's no different than a knee injury or a shoulder injury. It responds great to physical therapy. So we incorporate seeing a pelvic floor physical therapy into our practice for a whole variety of reasons, okay? So if pelvic floor physical therapy is an option for you, we will definitely set you up. And there's many great physical therapists in the community and around the Tucson Medical Center. So, but most people for overactive bladder, the first thing we talk about is medication. And bear with me, there's 2 categories of medication for overactive bladder. The older medications were called anticholinergic medication. And those are those traditional gotta go right now medication. You'll see the ads on TV for that. And they work. They're great. But they do have side effects. And they are slowly, and for good reason, not becoming our first line medication choices. And the main reason that I warn my patients to keep in mind is they can cause dry mouth, dry eyes, swallowing issues, constipation is a big one. But more importantly, a lot of them can actually impact memory. So we, as those who deal in incontinence, are really pushing for patients to realize that the older medications are no longer as appropriate for most of our patients over 50, given that we know there's subtle memory issues. So there are luckily other alternatives. There's 2 new bladder medications, not new, but and they're a different class of medication. They're called beta agonists. And one is mirabegron and the other is called Gemtesa. And they do not cause the memory issues and the dry mouth, dry eyes, and constipation that the older medications are known for. So we love the fact that even though medications in the past had a lot of side effects, they are the primary first thing we try with patients. And now we have newer agents that work just as well, if not better, than the older medications without any negative cognitive issues. So if you're on an older bladder medication, or if you want to know if your bladder medication could possibly be contributing to some memory issues, the 2 that don't are beta agonist medications, Gemtesa and mirabegron. All the other ones typically have a risk of leading to some memory issues. Okay. All right. So, but not all overactive bladder responds to medication. Oh, go back a couple slides. She's getting ahead of me. And back, back again. There you go. So what do you do if you've tried 2 medications and you come to see me and medications are not sufficient? So we have 2 things we can do. We can do Botox injection to the bladder, which is a wonderful therapy. We do it in the office. It is no worse than a blood draw. It's not uncomfortable. We put a little camera in the bladder and we inject Botox into the wall of the bladder. So the theory is if your bladder is really spastic and overactive, the Botox lets it relax enough that you don't have spasms, but still function so you can urinate. Botox is not permanent. It does wear off if you don't like it. But if it works for you, generally most people come in about twice a year and we top off the Botox and that helps with their bladder control. All right. The second option, instead of injecting something into the bladder directly, we can talk to the nerves that talk to the bladder. And this is called neuromodulation. And there's 2 forms of it that we typically use. Think of it, the best way I can explain it is, how you have pacemakers for when the heart's out of rhythm? Well, we have bladder pacemakers for when the bladder's out of rhythm. And there's a mild form and a more invasive form. So the mild form, bear with me, we kind of call it medical acupuncture because the nerve behind your ankle, which is your tibial bone, your tibial nerve lives there, runs all the way up your leg and joins the spine at the S3 nerve root, right near your lumbar vertebrae there. And those are the nerves that actually are the wiring for the bladder. So if we run a little electricity up your leg through an acupuncture needle, it actually tells the bladder reflex to calm down and you have better bladder control. It's a wonderful therapy, but it's a little time consuming. So most of my patients who choose tibial nerve stimulation are patients who live close to my office and don't mind popping in for therapy because 1, there's initial onboarding period where we get the therapy up to speed with you. And then there's maintenance. Usually about once a month, you come in and you get a session. So nobody wants to see me that often. So we set it up with our medical assistants so that you can pop in and out easily. And that makes it a lot more of a realistic therapy for our patients. A more permanent option is a bladder pacemaker. And that is talking directly to the nerves right up near your lower back. So the pacemaker works wonders. It's a permanent device. It can last up to 10 years. They are now MRI compatible and rechargeable. So it gives our patients an option where they don't need to come in all the time. Like for Botox or the tibial nerve, there's maintenance. If this device works for you, you're good for a while. There's a trial period. We give you a temporary device because we want to make sure it works for you before we implant something. But if it works for you, you come back from the temporary device trial and you either give me a thumbs up, Dr. Chesrow, I love this thing. Dr. Chesrow, and we look for other solutions. So my patients,
Dr. Chesrow, we were just having some issues with your internet, I think. So hold on just a minute and let's see if you resume.
and so for those my with an acupuncturist to go after your tibial nerve and see if it works for you.
Dr. Chesrow, you have frozen on us. Hang on just a minute. Let's see if we can get Dr. Chesrow back. We may have to have her join us again. Hold on just a minute.
Am I here?
Okay, so sorry, you froze up on us for a minute. So you can go back, if you can actually just go back just so we can recap where you were, just about the last minute.
What was the last thing you heard?
So I know, I think you were under you were talking about the SNS on the surgical options. So
okay, so I'll go back to sacral nerve modulation. Sorry if I repeat myself. I'm not sure where you lost me.
That's okay. You're good.
So sacral nerve modulation is a great option when your bladder is overactive. And the analogy I use is cardiac pacemakers or a heart pacemaker, which a lot of patients are familiar with. So when your heart's out of rhythm, you can have a cardiac pacemaker. When your bladder's out of rhythm, we can do a bladder pacemaker. The nice thing about the device is we give you a temporary one. So you do get to try it before we implant something permanent in you. And that lets you come back after the trial and really just give me a thumbs up, Dr. Chesrow, I love this device, I want it, or thumbs down, Dr. Chesrow, this didn't work for me. So the take-home message is we divide treatment of overactive bladder into kind of two categories. One, lifestyle changes and medication. But for our patients where medication isn't sufficient, then we talk about either neuromodulation through the tibial nerve behind your ankle, or permanent bladder pacemaker, or Botox injection to the bladder. And these are all really pretty minimally invasive. Even the surgical operation for the pacemaker is a minor procedure. So lots of great options there. And when you come in, lots of my patients who failed medication are thrilled with what we call the third line options. Okay, next slide. Okay, stress incontinence. So before, we were really trying to take this overactive bladder and get it to calm down and work appropriately. Like a motor that's running too hot, we need to get it to function slower so you can make it to the washroom in time. Stress incontinence is the leaky valve. So we have a valve that's leaking and we need to tighten it up. We need to tighten it up enough that you don't leak, but not so tight that you can't urinate. So this is where pelvic floor physical therapy and exercises really does wonders. Now, lots of women try and do these exercises at home, and I caution, don't get frustrated if you haven't had success at home. It's really hard to use the correct muscles and contract these tiny little muscles appropriately. So going to see a pelvic floor therapy, they will isolate the muscles that are important for continence and really help you with possibly a little biofeedback, strengthen them. And for people with mild incontinence, this can make a world of difference. So often for my patients with mild incontinence, I send you to a pelvic floor therapist and I say, I'll send you back every year or so as needed, and you don't need me as a surgeon until pelvic floor therapy no longer works for you. And it's a great option, okay? Another option is called a vaginal incontinence pessary. And you may have seen something like this at the drugstore. It looks kind of like a tampon. It's called the Poise Impressa. And all these devices do is this is your urethra that's moving around too much. It's a little device that sits inside the vagina and supports the urethra. So when you cough or sneeze, the urethra is supported and you don't leak as much. Now, with an incontinence pessary, it's medical grade silicone. If it fits you appropriately, you do not know it's there in the vaginal canal. It can stay in place for 3 months. It only needs to come out 3 to 4 times a year and be cleaned and replaced. Some of them, women can take in and out themselves and manage themselves without needing me. So that sounds like a great option. You know, a little ring you can put in whenever you want to exercise and then take out when you don't need it. And if a vaginal pessary fits you correctly, yes, it's a great option. But just like not every pair of shoes fits every woman, not every vaginal pessary works for every woman. So when you come in, we can do a pessary fitting and you walk around the office and see if it's a good fit for you. If it's uncomfortable, it doesn't work, then we move on to other options. I would say in general, all people who come to my practice, about 25% of the time, I can find an incontinence vaginal pessary that fits. And if I do, you think I'm a magician. They're wonderful. But for the other 75% of my patients, it's not a good long-term option. Okay, so we have this leaky valve that we need to tighten up. And there's really two great ways to do this. I'm going to jump ahead, though, to the more invasive surgical options because these are older procedures. And what I want to point out is with current technology, we really don't need to do these anymore. That they were more invasive, they didn't have the best outcomes. They either worked perfectly or for a lot of women, they didn't work at all and they sometimes caused more problems than they fixed. So under surgical options, there's bladder neck suspensions, what we call an MMK procedure or a Birch suspension. And many of you listening in may have had these procedures done. If they're still working for you, fantastic. And you have a little extra incontinence, we can really work around these procedures and salvage your old repair and adjust things. We don't have to take them down or redo them for the majority of the time. But they were invasive and the outcomes could be variable. So now going to the minimally invasive options, we have two great options. One is a sling and the other is injectable agents. And I will tell you there's a little bit more of a new injectable agent. So I will update when we get to another slide that injectables have become more and more of a realistic option for my women. So slings and injectables have been now so successful. The need for us to do these bigger procedures on you, bladder neck suspensions, MMKs, and Birches, has really gone by the wayside. And some injectable agents can be done with you just under a little bit of sedation, and you can go back to your normal life in a day or two. So great options. Okay, next slide. Okay, so we're going to talk about the two main things for stress incontinence, and this is what an injectable looks like, okay? So think about how women get filler to plump up their lips or their face. This is just a filler. So your urethra, remember I talked about how it's a valve, but it really shouldn't be open. The insides of the valve should form a seal and touch like two wet pieces of plastic. Age, genetics, childbirth form that seal to break, and you're left with an open tube that the urine leaks out of. The injectable brings the inside of that valve together and reforms that seal, and you're dry. So back in the day, there were two injectables, Coaptite and Macroplastique, that had variety of levels of success. There's a new injectable on the market. It's not so new, but there was a little delay with it coming out due to COVID. It's called Bulkamid, and it actually has data that it has efficacy near equivalent to a sling. So the lower success rates than surgery are really more pertain to the older two bulking agents. The new one, Bulkamid, while not equivalent to a sling, is close enough that for the majority of my women, a sling or an injectable, both are very valid options. So for my women who can't have a formal sling surgery, temporizing with a bulking agent is a great option now, and you will be dry if it's an appropriate therapy for you. The bulking agent now, we think it lasts at least between 5 to 7 years. So it's not like it's something you have to come in every year to get repeat injection. If it eventually wears off, we can repeat the bulking. So it's a wonderful flexible therapy for our women who don't have time for formal surgery. All right, next slide. All right, slings. So slings are wonderful. They've been around since 1968. They've been FDA approved since 1998. We've been using them forever and have great long-term data on their efficacy and how we put them in, okay? It is a surgery, you are asleep, but the incision is only about 2 centimeters and it's on the inside of the vaginal wall. Heals up very readily. You do have some time off activity. We like you not to do anything too strenuous, no exercise, no intercourse, no pushing, pulling, straining, while the sling is healing into place. So we put the sling in, but your body locks it into place over time. And then once that healing process is complete, you're good to go. And it remains a permanent part of you. So this is where I'm going to briefly touch on surgical mesh, because slings are surgical mesh. And many of you may have heard the surgical mesh controversy, seen the lawsuit ads, or you may have had a mesh complication yourself. And I specialize in seeing women post-mesh complications, correcting it, doing the reconstructive surgery, and I still do use mesh slings appropriately in my patients. So what I say in the short term is mesh slings are no different than anything synthetic we put in the body. artificial knees, artificial hips, pacemakers, heart valves. We put lots of synthetic material in the body for a variety of issues, but there's always the same risk with anything synthetic, that it could get infected, that it may not work, and that we may have to take it out. So anytime we're putting something synthetic in the body, that's the discussion we have with our patients. Luckily, mesh slings are a very small piece of synthetic, very low risk, and overall, the chance of having a significant complication with a sling, if it's put in by someone with appropriate training, is like 5%, which is pretty much the chance of having an issue with, any surgery that we do. So if a mesh sling is a consideration, or I think that's a recommendation I would make for you in your individual case, we'd have a discussion about that and go forward. But what I tell my patients is I wouldn't put things in my patients that I wouldn't use in myself or tell my own family to have. So just know mesh slings are the same synthetic mesh that you heard about in the lawsuits, but used in a different way that doesn't have the same type of risks or issues. And the lawsuits were about using mesh vaginally to lift up prolapse and really didn't pertain to mesh slings, okay? There are other slings we can do. We can actually take a piece of you. So they're called autologous. Auto means part of you. And we can take a little piece of tissue from your leg or just below your belly button and fashion a sling that is from your own tissue. And these are very successful. It's just more of an invasive procedure. And given that mesh slings have such low risk and are so successful, many of us use these autologous slings for more severe cases where other things have failed and we're doing a little bit more reconstruction. But it's a great option that's out there as well. So for stress incontinence, what I tell my women, really, there are bulking agents now that are as effective as the majority of slings, or slings are a wonderful option for my women. And we proceed with the choice with shared decision-making based on you, your unique health issues, and your anatomy. Okay. All right. Next slide. Okay. This just shows you what a sling is. It's a little hammock. It's literally a tiny hammock that goes under the urethra, and it sits there, and it should be tension-free. And what it does is whenever you cough or sneeze, it supports the urethra when you're doing activity. So really, all right, bear with me. This is your urethra moving around too much. It is literally just a hammock underneath. So when you cough or sneeze, you're supported. Okay. Now, there are 3 types of mesh slings out there. And if you're considering a sling, you really should see someone who uses all 3, chooses which type of sling they use based on your anatomy and your needs. So there's one called a TOT sling. It goes more laterally. There's a TVT sling. It goes more in an upward fashion, like a V, as a hammock. And then there's mini slings, which are smaller pieces of mesh that go to different anchoring points. And they all work for different types of patients with a variety of issues. So I just say, it's fair game to ask your surgeon what type of sling they use and why they make those choices. So you make sure that they use everything available and they're making choices based on what you need unique to you. Okay, next slide. Now, this is just where we touch again that mixed incontinence. If you have 2 reasons you leak, the basic analogy I say is, I got to fix both or you're not going to be dry. So if you have stress incontinence and overactive bladder, and I put a sling in you for the stress incontinence, you're still going to run to the washroom until I get you on appropriate treatment for the overactive bladder. And if I treat the overactive bladder first, you may not notice any change in how many pads a day you use until I fix the stress incontinence. And the reason we bring this up is a lot of patients have had other providers treat them for one issue and are very frustrated that they're not improved. And what I tell my patients who come to see me as a referral, keep in mind, you may just have 2 reasons you leak and the previous provider corrected one of them, but not the other. And this is a common thing we'll see where women have a sling put in or something for stress incontinence, but they still run to the washroom and leak. And that's because they need their overactive bladder addressed. Or women will try an overactive bladder medication, but still leak with activity. And that's because the stress incontinence or the leaky valve hasn't been corrected yet, just the overactive bladder. So if we say you have 2 reasons you leak, we'll work you through that process and set up a plan so you know at what step you can expect what improvement. Okay, next slide. All right, so this is pretty much the end of the talk, just kind of a general idea of what's out there for incontinence. And just so patients know, if it is bothersome to you, it's worth seeking an opinion on. It doesn't mean you have to do anything, but a good once over by an incontinence specialist can do wonders for helping you understand what's going on. And we always do shared decision making with our patients. My goal is primarily, first, not a surgeon, but as an educator. So when you come to see me, I want you to understand what's going on with your body and what I can and cannot do, and what results you can or may not be able to expect. And then you can make a good decisions about what treatment or no treatment you'd be happy with. So it's a lot of fun. We enjoy seeing you in clinic and figuring out what we can do to get you more dry and get you happier and have this not be such a big issue. Okay. All right. And I think next slide. All right. Lovely to talk to everyone. So a little talk about who works in the incontinence space. So back in the day, the incontinence space was really shared with gynecology and urology, and it still is. But they realized women's pelvic health issues were deserving of their own specialty. So now there's fellowships that train us in what we call urogynecology or female pelvic medicine and reconstructive surgery. And you'll see those initials after my name. It's a mouthful. It's FPMRS. And that means I did a fellowship in it, but I also sat down and took a whole second series of exams to be double board certified. So in general, you either want to see someone who specializes in female urology, urogynecology, and hopefully is an FPMRS specialist and has the board certification, because this is all we do. We focus our entire practice on the pelvis and pelvic health. Okay. All right. So if there's questions, I'm happy to stay and see if we can answer some questions for people.
So I do have some questions, Dr. Chesrow, that have come up. So one of the questions was about vaginal deliveries and why does that cause urinary incontinence?
Oh, a couple of reasons. Okay. That's an excellent question. And if someone has had a vaginal delivery, I really recommend you do pelvic floor rehab after your delivery. And I can't stress this enough. I always tell my patients, if you go see a pelvic floor therapist, you will give me less business later on in life. Okay. It's wonderful preventative measures and it really can help rehab those muscles. So a couple things. One, you can tear the muscles of the pelvic floor and that can lead to drop bladders and prolapse. Other times when the baby comes out, it can sit on the nerves of the pelvis and there's something called nerve crush injury that can change long-term throughout your life, how your bladder and your pelvic floor is innervated and lead to incontinence and overactive bladder later on. And sometimes, remember I said this is the urethra, those are the sport. When the baby comes out, the urethra gets taken off and you have a urethra and bladder that moves around too much. So you will notice after vaginal childbirth, your vagina is different. That's okay. It still works. It still functions. Pelvic floor therapy is wonderful. And there's a lot of minimally invasive things we can do for incontinence. Back in the day, we had, the medications with all the side effects, big surgeries. Now we can do subtle things in the office or really more minimally invasive surgeries to get you corrected and not leaking and more comfortable.
So if for your minimally invasive surgeries, are those on an outpatient basis as far as what kind of recovery time? They're all just an outpatient?
So most of the time they're outpatient. Sometimes if we're doing more than one thing, like we have to correct prolapse and incontinence, we may keep you overnight, but usually you go home the next morning. The main thing is our surgeries are pretty minimally invasive, but they have to heal depending on what we do. So you may have to take some time off work. You may have to avoid exercising for a bit so our surgery can heal. I always tell my patients, doing surgery is wonderful, but my surgery is the suggestion. It's your body that heals and locks everything into place. And you just have to give your body time to do its job. And that's what really makes a surgery successful. So for example, with stress incontinence, if we do a sling, we're going to have you take it easy for a bit because we don't want you popping our sutures in that little 2-centimeter incision. We want the sling to heal in place. With urethral bulking, we just ask you to take it easy for 3 days, but really you can go back to doing whatever you want immediately after. So for my women who don't have time for a lot of downtime, we have options.
Great. Now I've got a question here about somebody had heard that you shouldn't just go to the bathroom just in case. that, you need to have a reason. You really need to go. Can that lead to incontinence by just doing that? Like, oh, I'm on a road trip and I better just go.
This is actually a really good question. All right. Not to make anyone terrified. You can unpotty train yourself. All right. And I can fix it. We'll talk about it. And so can physical therapists. And also we see this in little kids who have what we call discoordinated urination. They push, they strain, or they bladder hold, and they can become adult women who have discoordinated urination. And surprisingly, when we see you, we may examine you and find that your pelvic muscles and your bladder are fighting each other and not helping you urinate appropriately. But how would you know? You've been urinating this way your whole life. Or after childbirth, with the muscle and nerve changes I mentioned, you may just be urinating differently, and it just feels different to you, but you wouldn't know. So that's why a good pelvic floor muscle eval and a pelvic exam, it's not as bad as it sounds, I promise it's not bad, really can tell us what's going on and what part of your pelvis we need to address. Now, there is something where we tell you, we don't want you to hold your bladder too long, like don't stretch it out. That's actually a real thing. But we don't want you to sit there and push and strain and get every last drop out. That can be just as bad as holding too long. So we actually, if we really need to see what's going on, we can have you do a bladder diary. We have you get one of those old school hospital buckets at home that go in your toilet, and we measure how often you go and how much your bladder holds, and we can adjust your habits. That is a standard thing we check when you come in to see us. So if you come to see me, you get to go home with a bucket. It's very exciting. And you come back and we look over it together and we see if there's any habits we need to adjust.
Okay, good. Now, and I know you've talked a lot about pelvic floor exercises.
Yeah, it's great.
TMC does have physical therapy.
Yes, they do.
And they actually have a program for that, for pelvic floor exercises. So if anyone is interested in that, you can reach out to TMC physical therapy for that as well. I have a question here asking, is there a way to determine whether pressure on the bladder is coming from obesity? Is that the cause, or would it be something else?
All right. So for my women who may have had a high body mass index and someone's told you your obesity is the cause of your incontinence, let me talk to them. Just because you have an element of obesity doesn't mean we can't treat your bladder and your incontinence. Okay. That is an old adage. And often it was from doctors who weren't comfortable with female health. They weren't comfortable with treating incontinence. They didn't want to do a pelvic exam and work you through the process. We are happy to see you. Rarely, all right, obesity is an issue, and there's very few people I won't treat due to your weight or any reason. So I want to give you peace of mind. It's not your fault. Incontinence is a normal part of aging. You are not doing anything wrong, and I'm happy to see you. And I have so many things that we can talk about to get you more comfortable. And I'm sorry if somebody told you that.
Good. Okay. And then is there a better option for an inefficient bladder?
Oh, yeah. Okay. So that's something we didn't really talk about today. And that's another reason for incontinence is we were talking about overactive bladders. As your bladder gets older, it gets smaller and spastic. It runs hot. But as we get older, some bladders can not function and they can get big and floppy, or they can not empty all the way. That's actually common in diabetics, some neurologic issues, some childbirth pelvic nerve crush issues. So if you come to see me and I find that you may feel on the outside like you have an overactive bladder, but on the inside, your bladder may not be working so good. Then we do other things to help you empty the bladder, and the bladder pacemakers, okay, that I talk about to calm down the bladder. Actually, in 50% of women, they can make an inefficient bladder start working again. It's one of the few things we have to really make a bladder that doesn't squeeze again. Now, there's a variety of reasons your bladder can stop working. I say it's plumbing and wiring. So the pacemakers aren't 100% for underactive bladder, but they really can help a lot of women get better. Now, if you have a bladder that truly doesn't work, some of you may be using catheters to drain your bladder, either on your own or leaving one in all the time. I would still see you and see if I can't get you catheter free. My goal is to get you comfortable and develop a catheter program that works with your life and isn't such a burden. A lot of times we find just coming in and getting a little catheter education and me tightening up your program and making sure you have the supplies you need and doing some education makes it such a better process and so much more comfortable and less of a burden on your life. So we're happy to see you for those issues too.
Excellent. Now, I just wanted to have you just briefly mention again about the lawsuits and the slings.
Oh, yeah. Okay.
Just explain that these are not, from what you had said, these were not related to those lawsuits, the
No.
slings that you were referring to.
So what I
Can you
tell
just
my
clarify
women,
that?
yeah, so what I tell women, you know, and if you come see me, I'll go over the FDA warnings and lawsuits, but it's sadly an area where lawyers, the FDA, and doctors let the female health population down. And in general, if there's issues with the device, we do research and development, we get better standards, and we improve things so things move along. Think about the first heart valves that they put in, like these big metal heart valves, and now we can do minimally invasive heart valves. So instead of improving mesh in the female pelvic space, we just took it away, but we didn't take it away all the way. So the only place that they put a hold on vaginal mesh is where we go through the vagina for prolapse, not for incontinence. Prolapse is when you have a dropped bladder or a dropped uterus or the vagina, there's a big bulge at the vaginal opening, and we would put these grafts in through the vagina and lift things up. We can still use those grafts, but we put them in robotically through the abdomen. So instead of pushing you up from below, we can lift you up from above. And to my patients, I know that seems like splitting hairs, but how we put them in really influences how you heal. Now, putting a small mesh sling vaginally through a small incision above the urethra is very safe and was never a part of the issue. So for those of my women who are listening right now who had issues with mesh, truly, a lot of times it wasn't put in correctly, or they didn't make good choices about which patients should have it, or these patients weren't able to heal. And so what happened is the mesh worked its way out like a splinter and formed an open wound, and it caused a lot of women a lot of problems. So I actually specialize in biological grafts using mesh. That's what some of my research was on in my fellowship, using biological grafts as an alternative to synthetic mesh. I still am very comfortable using both, but I think we did women a disservice when mesh first came out, and a lot of women had terrible outcomes that we are still seeing them and correcting them. So mesh slings are a very safe way to use a synthetic for treatment of incontinence. We still do use mesh in prolapse, but we only put it in through the abdomen, not through the vagina. And I know that seems like splitting hairs, but what I say is we still put tons of synthetic devices in people. We just need more research, and we need to make these products better and safer with better standards.
Great, thank you for that clarification. So the last question that I had come in actually is asking about males. Do you treat males with mixed incontinence?
I do. In urology, male incontinence is kind of split up into a couple different areas. There's, for example, post-surgical incontinence for men who've had their prostate removed, and they'll often see I'm a female reconstructive specialist, but they'll see a male reconstructive specialist because we have slings for men and we have artificial urinary sphincters for men. But I see men who have complicated bladders. So they have a neurologic issue. They may have mixed incontinence, both stress and urge. So if you need a very fancy plumber, male or female or trans, I am the very fancy plumber. And so I do complicated incontinence.
Great. Okay. I would like to just end with just how people can get in touch with you, Dr.
Oh, perfect. Yeah.
So I have put up your phone number here for the office over at Arizona Urology Specialists, located over on Tanque Verde.
Yep.
The phone number is 520-795-5830, or you can try the website at arizonaurologyspecialist.com. If you are interested in any more information. And I really appreciate you being here today. That was very insightful. There were things I had not heard of before. The pacemakers, I hadn't heard of that procedure before. And just to hear that there are so many new minimally invasive surgery options for folks, I think is really going to be very helpful for many of our seniors. So thank you so much for being here, and I look forward to seeing everyone again tomorrow. Tomorrow we have our class on varicose veins, prevention and solutions with Jennifer Clark of Pima Heart and Vascular. And thank you again, Dr. Chesrow.
My pleasure.
We look forward to seeing everyone again.
Thanks so much. Have a great day.